So I think we should start right now. بسم الله السلام عليكم ورحمة الله وبركاته والصلاة والسلام على نبينا محمد وكل عام وانتم بخير. Good evening everyone. Welcome to our webinar. My name is Dr. Abdul Majid Aziabi. I am assistant professor at JSN University College of Engineering. I am interested in human factors engineering and patient safety culture. This evening, you will be hearing a presentation from Dr. Jeffrey Salbon Harman. He will be speaking to us on human factors analysis and classification system in healthcare. Dr. Jeffrey Salbon, he is a certified physician executive, and he is a certified professional in patient safety. Also, he is a Presbyterian Healthcare Service Chief Patient Safety Officer and Vice President of their Quality Institute. He oversees and manages quality, patient safety, infection control, and process excellence while leading a high reliability transformation rooted in just culture and standard daily work. Dr. Jeff spent about 20 years of active duty in the United States Public Health Service after completing his medical degree at Tufts University School of Medicine in Boston and his residency in family medicine with Caroline Health System. He is certified physician executive at American Association for Physician Leadership and certified professional in patient safety. So kindly notice that the question will be at the end of the session and post in the question and answer icon so our speaker can answer this. So now moving along to our session, please welcome Dr. Jeffrey to deliver the presentation on this very timely subject. Welcome in, Dr. Jeff. The mic with you.
Thank you so much, Dr. Aziabi. Thank you, and good evening, everybody. It's really a pleasure to be with you and to share with you about the human factors analysis and classification system adapted to healthcare settings. Our core objectives for this presentation are to explain the concepts of human factors and the application in the healthcare event learning environment. And when I say event learning, that's a term that we use in place of adverse event, unanticipated event, or patient harm event, because ultimately what we're trying to do is learn from these events and improve our systems. I will also be demonstrating a model of incorporating the human factors analysis and classification system, or HVACs, into root cause analysis processes, and then demonstrate deeper learning from our healthcare event learning when we apply HVACs to root cause analysis. So let's start by defining what we mean by human factors. For many people, human factors relates to ergonomics in the work environment. And we're going beyond that. When we talk about human factors in this setting, we will be talking about those organizational, individual, environmental, and job characteristics that influence behavior in ways that can impact safety. And in particular, in clinical and healthcare contexts, that means lives are at stake. So this definition comes from the Clinical Human Factors Group out of the UK, led by Martin Bromley, whose wife suffered an adverse event in the operating theater for a relatively benign and minor condition, but that ultimately ended up costing her her life. And so we think about human factors in terms of those things that can go wrong in the healthcare setting that may lead to unexpected outcomes, complications, or adverse events. Now, to dive a little deeper into it, the roots of human factors analysis classification come from the work of James Reason. Reason was a psychologist from the United Kingdom who devised this model, frequently known as the Swiss cheese model of accident causation. And the thinking is that each layer of the cheese represents a layer of defense against adverse outcomes, but that it's the holes in the cheese, particularly when they align one to another, that allows a sequence of events to occur that ultimately results in that undesired outcome. And so he began to label those different layers of defenses. Those are organizational influences, unsafe supervision, preconditions for an unsafe act, and ultimately the unsafe act itself. And again, when all of the holes line up, it allows a sequence of events to occur that may yield an undesired outcome. Now, within the model, he also defines these ideas of things like a near miss or a good catch, those things that almost reach the patient. And we can also think about human factors in healthcare in terms of things, events that occur that have an undesired impact on our workforce too. So a near miss or a good catch could be something that almost affects a workforce member, or it can be something that almost reaches a patient. You can think of examples like a mislabeled medication from pharmacy, or an improperly dispensed medication in pharmacy. You might think about any procedural space like the operating theater, where maybe the wrong anesthetic gas, or the wrong patient for the right procedure, or maybe the wrong procedure for the right patient, but catching that before it actually reaches the patient or the workforce member. Those would be good catches. Our active failures are those unsafe acts that occur at the point of care. And that's what defines them as active. It's that act of commission where we do something while we're involved in providing care that results in that adverse event. The latent failures are more difficult to identify many times. Latent failures are the influences that are below the surface, that we don't have ready visibility of, but that are driven by our processes behind the scenes. They're driven by things like procurement and equipment maintenance and management, policy and procedure, hiring practices, human resources practices, interactions between people that can impact our mindset and how ready we are to execute on a particular operation. And then those can ultimately culminate in the event or the incident. So you can think of two different groupings or taxonomies for those slices of the Swiss cheese, those on the left as well as those on the right. They have some overlap in that the latent failures tend to be those preconditions, unsafe supervision, and organizational influences, where the active failures are the unsafe acts at the point of care. So I want to introduce you now to the human factors analysis and classification system, which is essentially a taxonomy, a classification system that allows us to label and identify very specific behaviors or influences on behaviors that contribute to adverse events. And by having an alphanumeric system of capturing those assigned codes when we identify those human factors, we can begin to build a library of the frequency of certain latent failures that contribute across multiple different unrelated events, making human factors analysis and classification much more powerful in looking at system influences that we want to try to redesign. So originally, HVACs was designed or developed for the United States Navy, in particular for aviation events. And so you can imagine the aviation environment is very specific compared to our healthcare environment. And so over time, what was realized is that this framework for HVACs could be adapted actually to multiple different environments. It was developed to increase the depth of learning from aviation mishap investigations, meaning when an aircraft crashed or when some part of the aircraft was damaged through an inadvertent action, or in some cases even advertent action. We wanted to understand more than just to say, well, it's a material failure or it's pilot error. We wanted to understand the underlying drivers for those things. And as I mentioned earlier, identifying those common root causes where we can aggregate those again across multiple different events and have an additional layer of learning that otherwise would not expose itself. And so over time, this model has been adapted to other environments like rail transit, like energy production, the nuclear industry, a number of high consequence industries that rely on high reliability. And this becomes the key tool in learning in that high reliability environment to redesign systems. And so this is a snapshot of the human factors analysis and classification system, or again, HVACs. And it starts from the bottom and it works its way up. That's the purpose of that red arrow on the left, is to indicate the progression as we apply it during an investigation. And we'll go into each one of these layers in a little bit more detail. But again, we start from those unsafe acts. And so this is building on the James Reason accident causation model, moves up into the precondition for unsafe acts, then to the supervisory factors, and finally to the organizational influences. Looking at each of those in a little more detail, we start with the unsafe acts, and those are divided into two big categories: errors and violations. One thing I want to say at this point, and I will reiterate it a few times through the presentation, is that the nomenclature, the wording that we use in this model, is sometimes not the wording we would use in discussing it with people outside of the patient safety world, because it sounds very judgmental. When we talk about violations, there's a lot of judgment attached to accusing somebody of a violation or identifying that somebody has violated a rule or a protocol. And so in this model, these terms are used non-judgmentally. A violation is simply defined as the disregard or the overriding of existing guidance or rules for whatever reason. And sometimes there's a right reason for that as well. So I really want to make sure that we set that stage, that some of the terminology can be very loaded, may not be understood by others when we talk about things like failures and inadequacy and violations, but these are non-judgmental descriptions of current state. And we may want to substitute different words for those when we share findings from HVACs with others outside of patient safety. So within the unsafe acts, we have errors, which are divided into decision errors, skill-based errors, and perceptual errors. So a decision error where we've made the wrong decision. We maybe didn't have all of the facts, or we misconstrued the facts. A skill-based error where we maybe don't have the physical skills through repetition and practice to prevent a complication. We're maybe earlier in our learning journey and we don't have as many hours of practice. We can think about pilots and the number of hours at flight controls, and how within the first 1,000 hours, they're more prone to mistakes. And similarly, after 5,000 hours, they're also more prone to mistakes, but for different reasons. And then perceptual errors, where we may misperceive cues from the environment. And that can be driven by the design of those cues, that can be driven by our physical state at the time, the environment around us, and being able to perceive those. With the violations, now we go from the inadvertent actions, so errors are typically unintentional, to now volitional or intentional actions. And we divide the violations into both routine and exceptional violations. Now, routine violation refers to a set of behaviors or practices that have been normalized within a group, right? So it's the way we've always done things here, even if it's different from what policy says, right? We hear those kinds of statements. Normalized deviance is a term that we use officially for that when we're identifying routine violations. As opposed to exceptional violations, which means one person did something that nobody else in their cohort or their peer group would have done. So it's a standout, it's an outlier of behaviors. We'll move on next as we move upward in the classification model to our preconditions for unsafe acts. And here we have three categories of situational factors, conditions of operators, and personnel factors. Within the situational factors, we look at the physical environment, like the space layout, the temperature, the lighting, literally the physical environment in which we're operating, whether it's an inpatient room for 1 or 2 patients, it might be the operating theater, it might be an outpatient procedural department within the hospital, it might be an imaging department. We look at the size of the equipment in the room, we look at the workflows and the movement of people around the room for those physical environment aspects. We also look at the control of the climate within the room, and whether it's kept at a workable temperature and what the reasons are behind that. We also look at tools and technology. And so we might have outdated equipment, or we might have equipment that hasn't maintained as well as we would like, and that's prone to malfunction. And that might get into other factors around the choices in procuring those at the organizational level. But we look at those tools that are being used and whether they're proper for the intended purpose, or whether we're working around the absence of that proper tool. For the personnel factors, we look at the communication, coordination, and planning of activities. And the capabilities to communicate and coordinate effectively, the tools that we're using, do we have checklists, do we have procedure cards, et cetera. We also look at fitness for duty of the individual, meaning their medical condition and whether they have any impairing conditions. Are they exhausted, fatigued, distracted, et cetera? Have they been on call for an excessive amount of time, and so are more prone to error or judgment issues as a result of the fatigue from that disruption of circadian rhythms. For the condition of operators, we also look at their mental state. Are they subject to distractions or to mental stresses, both in their home life or in their work environment? We look at their physiologic state, like becoming dehydrated if they've not had access to water for an extended period of time during their shift or during a particular procedure. We also look at physical and mental limitations, whether we're expecting them to be able to operate beyond their scope of knowledge or skills. All of these come together in the condition of operators. At our next level, we look at supervisory factors, and those begin with inadequate supervision. Again, here's one of those terms that can sound very judgmental: inadequate. A replacement term could be insufficient, but you might mention competencies so they could function independently. Next, we have planned inappropriate operations. In this case, it would be too complex of a procedure, perhaps, for the capabilities of the team. It might be introducing a new procedure that is the only likely benefit to the patient, but that a team hasn't been properly prepared for, so that they're ready not only for doing the procedure correctly, but also for the contingencies that might arise. Failure to correct a known problem can sometimes have a relationship to conduct of an individual and whether that conduct is addressed. But it can also be problems with supply chain, equipment and materials, or their absence that may increase the risk of performing a procedure or conducting a diagnostic study, for example, without all of the appropriate materials that are necessary. Or because those materials had failed but hadn't been taken out of service until a replacement had arrived. And then lastly, a supervisory violation. And so again, that's the intentional act by a supervisor giving direction or orders to others that are outside of the scope or boundaries of policy, procedure, best practice, or even licensing standards. And then our last layer is the organizational influences. And so this is where we see organizational culture, and in particular, in this context, the culture of safety, and whether or not safety is prioritized by the organization, and in particular, all of the people that operate within the organization. Because remember that an organization is not actually a physical entity, it's a group of people who align with a particular mission to provide a set of services. So the culture of that organization can have an enormous influence on the perceptions around safety, as well as what's permissible or impermissible activities. The next one is operational process. And so that's the defining through policy and procedure how things are to be done, and the setting of specific rules, like hand hygiene, for example, and the World Health Organization 5 moments for hand hygiene, or using dual identifiers for any patient before drawing blood, administering medications, or performing any procedures at all. And then lastly, resource management as an organizational influence, meaning our processes through supply chain and contracting and procurement, and even hiring and setting of staffing standards. All of those fall into this category of resource management. So that's a pretty quick overview of the human factors analysis and classification system and its categories. So at this time, let's take our first poll.
So right now, thank you, Dr. Jeff. Right now, you will see the first question, poll question, which is, which of the following categories is not defined in the accident causation and HVACs model. We have about 5 answers. I ask the participants, please try to answer this poll question so Dr. Jeff could get a clear picture of your understanding. We have about 30 seconds to answer this poll question. I ask the participant, could you please try to answer this question? So as it appears for me from these answers, the largest percentage goes for the organizational influence, is about 27%. The second one is regulatory readiness. I mean, the first one is regulatory readiness. The second one, organizational influence, is about just 1% between these two answers. Go ahead, Dr. Jeff.
Thank you very much. So regulatory readiness, option B, is the one category not defined in our human factors analysis and classification system model. Understandably, I'm sure many of you see the connection to regulatory readiness of learning from events and applying the HVACs model. But organizational influence, unsafe supervision, preconditions, and unsafe acts, those are the names of those 4 slices of Swiss cheese from the James Reason accident causation model. So let's continue on then. And what we will do now is dive a little deeper into the adaptation of HVACs in healthcare now that we've talked about the model itself. So HVACs in healthcare resulted from a close partnership between a physician and the military HVACs developer, Dr. Scott Chappell. I myself in 2015 was thinking about making this adaptation. And as I started my literature review, came upon Dr. Thomas Diller's work in 2014, in which he had already made that adaptation that I had in mind. And so his intention was to bring attention to the applicability of the HVACs model from the military and to the healthcare setting. He focused on 4 weaknesses of root cause analyses. And so some of you may have observed, may have experience with some of these, what we call, or what he called weaknesses. The first is that the use of root cause analyses, or RCAs, was non-standardized and it was unreliable between organizations. So if you've seen one RCA at one organization, you couldn't translate its results to another organization. There was too much variability in the process and too many people doing it different ways. Additionally, there was an excessive focus on blame instead of learning in root cause analyses. So instead of focusing on the system and its design and how the design does not anticipate the potential risks or problems that the workforce might encounter in order to keep patients safe, it focused too much on individual accountability and punitive responses rather than system redesign. Also, identified causes were too non-specific and didn't result in actionable corrective plans. So if we think about things like aviation mishaps, for example, many times we hear that pilot error was the cause. And I would submit to you that pilot error is very non-specific and so cannot be a cause in and of itself. If a pilot made a mistake, then it was for a reason, and we have to dive deeper to understand those reasons, and HVACs helps us to do that. Similarly, if a physician or a nurse or any other healthcare provider in the allied health professions were to make a mistake or do something incorrectly, we need to be able to dive deeper into it than to simply identify that it was them, because ultimately, the vast majority of times individuals make innocent or inadvertent mistakes rather than intentional acts. And so we want to be focused on designing the system around the knowledge of those failure points or those vulnerabilities in order to prevent the adverse events from occurring. And then lastly, Dr. Diller identified the standardized nomenclature was not available to analyze recurring failures across systems. So as I talked about before, where we can aggregate multiple human factors across different events and see similar causes, it allows us to redesign our system in a different way than we've ever been able to before. And so to go into a little more detail on that, as I mentioned with root cause analysis, the typical findings are summarized here, that they're individualized to the specific events rather than being generalizable across systems. There's not a specific nomenclature or taxonomy or coding system. So different systems might be calling the same thing by different names, and we lose reproducibility and we lose commonality. Often there's the included focus on who for purposes of blame and discipline, and we really want to stay away from that as we create cultures of psychological safety, because the person who is most directly involved is the person with the most knowledge about how it occurred, and we need to learn from them. And as soon as we blame and discipline inappropriately, the opportunities for learning disappear. And then this limited capacity for aggregation of events is common to root cause analysis because of that absence of common terminology and the variability in process. When we look at HVAC's typical findings, we see this standardized process and nomenclature across the multiple events. We see a coding system for aggregation of results and statistical analyses, so that we're using that same terminology and the same coding classification, whether we're in one part of the world or another. We dive deeper into the finding of human error by identifying the various different individual and predisposing and environmental circumstances that may result in that error. And we focus primarily on the what, the how, and the why of an event, rather than on the who. So I want to share some typical findings from HVAC's investigations or HVAC's application to root cause analysis. Starting with the unsafe acts, and we'll work our way up the taxonomy. When we look at errors, the skill-based errors break down into these categories, and I'll just highlight the top scoring or the most frequent identified elements within each category. So within skill-based errors, we see timing errors, safety checklist errors, and work or motion at improper speed. So usually improper speed would mean trying to do something too fast, and that might result in either fumbling an instrument or nicking a tissue unintentionally. Timing errors could relate to the performance of a certain phase of a surgery or a procedure out of sequence and ahead of time or delayed. As we shift to the middle segment with errors in decision, we see inadequate risk assessment. Again, inadequate being a potentially judgmental term, but in our context, inadequate meaning simply not meeting the needs of the moment. Also critical thinking failures and cautions or warnings being ignored or misinterpreted. I want to spend a moment on that one because oftentimes the ignoring or the misinterpretation of a caution may come from having authority gradients in which somebody who's in a lower position of authority, but who has the requisite information is not listened to because they are not the authority figure. And that ties into high reliability practices, and in particular, one called deference to expertise. So recognizing that not one person cannot have all the answers every time, every minute, for every question and every circumstance. It takes a team. And sometimes even the person who's highest in leadership of that team may be distracted or could have their attention channelized and be missing certain external cues that are being picked up by a team member. And so that willingness to listen, to defer to expertise in moments where we might be otherwise accepting too much risk is what this is speaking to. And then at the bottom of the slide, the perceptual errors, such as misperceived patient factors or misinterpreted and misread equipment. And you can see how relatively infrequent that is compared to the decision-making errors. Next, if we look at the violations subcategory within unsafe acts, the typical routine violations we see are the violations of policy, procedures, and standards of care. And again, because these are the routine violations, that means that this is a groupthink situation. This is a circumstance in which an entire team has decided to disregard a particular rule or procedure, maybe because one person in authority advised that it was acceptable or there was no increased risk and everybody followed suit. Other times, maybe because it was perceived as a cost or a time-saving measure to do something differently than the policy, procedure, or standard of care. When we look down at the exceptional violations, and here you see again, numbers are much smaller than the routine violations up above. In this category, we see the violation of policy, procedure, and standards of care by an individual, not as part of a group, not the normalization of deviance that we've talked about before, but this is a lone actor who's choosing to deviate for their own reasons. And that's usually where we're going to get into disciplinary types of reasons for that behavior, particularly when we think about a just culture model applied then to what we learn from events in a root cause analysis with human factors. Shifting to our next layer up, the preconditions for unsafe acts, we have our personnel factors. And beginning with our communication, coordination, and planning factors, you see the most prevalent factor of all, the inadequate communication between providers. In this case, providers means any clinician within a healthcare setting, not just specifically physicians or mid-level providers like nurse practitioners and physician assistants. And so this really gets at the human component of how we interact and how vital communication is between us for sharing of vital information to keep patients safe, vital information for quality of care, for intended actions, for readying during a transition, for example, a transition of care, readying the receiving team for potential complications that they may not be thinking about because we have additional context on the patient having already been providing care for them. When we look down to the personnel factors in fitness for duty, again, very small numbers here suggesting this is probably underreported when we know firsthand what the fatigue levels are like, whether it's nurses who are working 12-hour shifts or maybe are asked if they could stay on to work an additional shift because of a staffing shortfall. So now they're working 24 hours continuously. We know for residents when they're training, physician residents, also for physicians practicing in an on-call environment, that they may exceed what we would consider safe rest or waking hours in the course of their duties. And that there's a lot of professional pressure to continue to try to function despite that fatigue. Looking also at our conditions of the operator under the preconditions for unsafe acts, the adverse mental state category, we see task overload dominating that category. Medicine becomes more and more complex every day. Electronic medical records have added complexity. The rapid advances of technology have added complexity. The volume of information that healthcare professionals have to retain and act on, all of that results in task overload. Coupling that with busy inpatient services, high patient volumes, staffing ratios for inpatient support, clinical staff, as we try to economize on our healthcare dollars can all result in task overload as well. When we look at the adverse physiologic state, we also see task overload in the middle graph there. But again, probably underreported or at least not attributed as much to the adverse physiologic state as to the adverse mental state. And then at the bottom, looking at chronic performance limitations, we see similar numbers for limited experience and proficiency and lack of technical procedural knowledge. In general, I believe that our healthcare professional educational systems do an incredibly good job of educating and developing skills, but recognizing that in some systems there may be shortfalls, some of which is culturally driven. When I trained in medicine, it was not uncommon for physicians to learn a new procedure using the see one, do one, teach one model. And just 3 iterations of a complex procedure may not be enough to really assure competency. And so looking at new ways of managing the skill development as well as the confirmation of competency becomes quite important. When we look at the environmental factors of preconditions for unsafe acts, we see in the physical category that inadequate and improper design for patient care is the leading influence. And so that's where we may find out that somebody's developed a piece of equipment, a technology from an engineering perspective, but without really looking at the human interface or without looking at how it functions in a healthcare setting or without looking at how it interfaces within a particular grouping of pieces of equipment as part of a procedure or part of a patient monitoring process, for example. And so things like multiple push buttons, lots of alarms, dials instead of buttons, a multicolored display that maybe doesn't account for the prevalence of color blindness in males, et cetera. Those would all be examples of inadequate or improper design for patient care. And then within the technical category, we have poorly designed or inadequate equipment, material, PPE, and instruments. Not nearly the same prevalence as we saw above, but again, things like material in nitrile gloves that is not resilient enough, doesn't have enough elasticity, so gloves tend to break, or an isolation gown that is not fluid resistant enough such that it protects the wearer from that potential bodily fluid pathogen exposure. Shifting gears to our supervision category as we continue working our way up the hvacs taxonomy. We look at inadequate supervision, and we see inadequate mentoring, coaching, and instruction, as well as inadequate oversight as the leading categories there. Again, examples that I provided earlier would be somebody who assumes a level of knowledge or skill because of somebody's qualifications, but hasn't actually validated that those skills are present. In the next category down, failure to address a known problem, failing to initiate a corrective action, whether it's for equipment failure or whether it's for undesired behaviors in a staff member, or whether it's corrective action for human resource problems, policy violations, et cetera. Those behaviors that in a just culture model would warrant discipline, essentially. In the inappropriate planned operations category, the failure to match staff competency with the task, that's a responsibility of a supervisor, is to make sure that if you're asking a staff member to perform a specific function, that they actually have the validated competency to perform that function. And then lastly, in the supervisory violations, we see the most significant contributor, which is the failure to enforce policies and procedures. And so that's recognizing the conscious failure to enforce, as opposed to the not knowing that staff are not following a particular procedure. There's that difference between, similar to violations and errors, the inadvertent action versus the knowing or intentional action. So in this case, we're talking supervisory violation. We're talking about the intentional failure to enforce. And then our final category, the organizational influences. We look at resource management, and I used the example earlier of inadequate staffing as one of those resource decisions that are made. And that can be physician staffing, nursing staffing, allied health professional staffing, et cetera. It's not specific to any one professional discipline. You can see how that dominates these categories. In the organizational climate, the inadequate policies. I think one of the policies that's getting a lot of attention right now for workforce safety is policies on incivility of patients and visitors, as we see, at least within the United States, increasing volume of violent actions against healthcare professionals in multiple different settings across inpatient systems. And then under organizational processes, the strategic risk assessment. So looking at the enterprise level at what risk tolerance we have, what economic and resource values come up against safety risks and the readiness and willingness to undertake those risks. Again, dominates over the corporate procedures. So those are examples all from Dr. Diller's work, where he compared about 1,100 RCAs against the hvacs model and derived these many findings. So at this point, let's pause for our second poll.
This is the second poll question. I asked the participant to participate in this question, which is the most frequently identified human factor contributing to adverse event in healthcare is. We have 5 answers. Please pick one of them. We have about 30 seconds. We have about 10 seconds. So from your answers, the highest answer is the inadequate communication between providers, which is 29%. Go ahead, Dr. Jay.
Thank you very much. So well done for those of you who responded in that 29%. That inadequate communication between providers is the most common precondition for a human factors or identified precondition of human factors for adverse events. So we'll continue on then with our final segment of the presentation. we're going to talk about how to operationalize HVACs in healthcare, starting with categorizing events. So part of the application is deciding which events you're going to look at, because you may be resource constrained in terms of how many events you can thoroughly analyze. Particularly using HVACs is a little bit higher level of effort for your investigative teams. And so I'm going to walk you through the model that we've developed at Presbyterian Healthcare Services in New Mexico for patient safety investigations, as we have relabeled root cause analyses. So it starts with identifying these 4 categories, and these may look familiar to you because they're very similar to the Institute for Safe Medication Practices medication event reporting procedures with the A through I classification. So we've then distilled that down into just 4 categories for our management at Presbyterian. So category 1, we have the unsafe conditions, which can result in harm but have not, so near misses. In category 2, we have safety events, which are lower level events that reach patients and don't result in any significant disability or harm, but they might extend the stay or might require an additional treatment in order to prevent complications. Category 3 with serious safety events, these are those events that are reported under the term SSE, or serious safety event, and can result in temporary harm, initial prolonged hospitalization, major temporary harm, or even major permanent harm. And then the last category 4, the extreme safety events, where we see near death and the requisite interventions to preserve life and limb, or an adverse event that results in death of the patient. In order to get to those 4 categories, we've created a scoring matrix where we look first at the severity of illnesses occurring and multiply it by the priority seen in the blue labeling across the horizontal axis, the patient safety priority rating. And I'll speak to that priority rating more in just a moment. So the severity essentially aligns to the ISMP, MERP scoring that I just mentioned. And you can see some labeling in the adjacent column: negligible for the A's, B's, minor for B's and C's, moderate for D's and E's, major for F and G, and catastrophic for H and I. And then the patient safety priority rating is really a reflection on the frequency with which those events are likely to occur. So this is that classic calculation where risk equals severity times frequency. And from that, then you can see the color coding that's applied for low, medium, high, and extreme risk in those 4 categories that were defined on the previous slide. Specifically, to talk more about the patient safety priority ranking, values were assigned to different event type classes. So for example, if somebody has a code blue cardiac arrest, it's accorded 10 points. So it's the highest severity event that occur. Equipment failures, on the other hand, warrants a score of 3. Falls with injury, a score of 5. IV, meaning intravenous medication related events, a 1, and so on. So you can see the scoring priority that's assigned based on both the frequency of these types of events that occur within our health system. And as a result of that, then we have an example over on the right side where, for an example, a significant score of 7 was identified, and a patient safety priority ranking score of 9 was identified, giving us a point total of 63. And so with a point total of 63, that would classify under H as a high risk event that would warrant investigation. But we can go one layer further, and we can also apply what's called an emphasis factor. So in order to add additional weight to events that carry not only a high frequency, but a severity that is greater than others within that same ISMP, MERP category. So we added these emphasis factors, scoring 2 or 3, that can subsequently then be applied to the initial score. So remember our score of 63, 7 times 9. If we then also apply the emphasis factor of 3, gives us a score of 189, which on this multiplied score with the emphasis factors also scores very high in the high category and confirms that high score. Now, the reason for identifying these priority ranges is that you can prioritize investigation from the most extreme depending on your resourcing, meaning the number of investigators that you have and the time that you have. So you might start by focusing on just your extreme events, but if you find that your team has additional capacity to do more investigations, you might then start also investigating your high scoring events. But you might decide that your medium and your low scoring events don't offer enough opportunity for significant system redesign, or that they'll be looked at through what's called an apparent cause analysis rather than a root cause analysis, which is essentially a record review, but without actually investigating by interviewing individuals, visiting the site, et cetera. So by using this prioritization, it allows you to decide on how to use your resources for investigating. Because as I said, to do an investigation with HVACs requires more time and more effort in the interview process, identifying and cross-checking the various different factors in the HVACs model. We then built our patient safety investigative workflow that you see here, starting from an event or error or unsafe condition that resulted in some adverse event, the scoring that you see just below that in the gray block, and then prioritizing our category 3 and 4 investigations, launching our patient safety investigation team, bringing them back together within 1 or 2 weeks of launching the investigation to share progress made in the investigation, preliminary findings, and for any additional thinking in a group shared setting, but only within the quality protected setting of patient safety investigators and quality managers, not with the general employed workforce, so that we can maintain our quality and safety protections medical legally. And so as you can see, it progresses through 2 more team meetings and then is ultimately presented at what we call our significant clinical event review team, where a cause flow map and our key findings and action plans are defined and presented for acceptance as then work progresses with those action plans. And then in preparing to close out, a summary of action planning as relates to our HVACs investigative process. This pulls from the Veterans Administration National Center for Patient Safety, was incorporated into the National Patient Safety Foundation Root Cause Analysis and Action Framework, or RCA2. And it defines a hierarchy of actions. It begins with these weaker actions of double checks, warnings, new procedure, memoranda, policy, and training, meaning training of people who are already trained, not foundational training for folks who don't have the information at hand. It progresses to these intermediate actions that are likely to better protect against those types of adverse events that we've observed. Starts with design redundancy. Having a backup method or process or additional duplicative resource in place to prevent a single point of failure. Increasing staffing, decreasing workload, software enhancements and modifications to address gaps in software programming, eliminating and reducing distractions. I can't speak to how important this is, particularly in medication preparation areas and with medication lockers, to avoid distraction so as to prevent miscalculations or the pulling of a wrong medication, or the distraction from the ability to focus on the state of a medicine that might indicate it's the wrong medication. Meaning, is it a liquid, is it a powder, is it a gas, et cetera. Education using simulation, so not just didactic education, but creating learning experiences. Using checklists and cognitive aids for timeouts and huddles, eliminating look and sound alike medications, procedures, equipment, standardizing communication tools so that we, again, are using and avoiding the lookalikes and sound-alikes. And then enhancing documentation and communication. So using tools that help us to communicate more effectively, as well as clearly documenting care provided and identified risks. And then lastly, our stronger actions are where we physically redesign a space or a workflow. We introduce new devices that have undergone usability testing, so we know that they're compatible with ergonomics and with human behaviors and perception. Using engineering controls like forcing functions. So for example, the gas line inputs on the wall in an inpatient setting, having different fittings for different gases, so you can't inadvertently plug the wrong tubing into the wrong gas line. Simplifying processes by removing unnecessary steps that don't necessarily add value or safety. Standardizing on equipment or processes in a large complex system. If you have teams who move between different units or different hospitals or facilities, to have the same equipment in those different locations so that there's no confusion moving from one setting to another. And then, of course, tangible involvement by leadership. Leadership has to be outspoken about the importance of a culture of safety, the importance of high reliability practices and standardization, and using the information coming from HVACs to inform those decisions about system redesign and possibly equipment reprocurement, et cetera. And so at this point, we have our final poll.
Thank you, Dr. Jeff. This is the last and third poll question, which is: a risk stratification scoring system is necessary for incorporation of hvacs into healthcare root cause analysis. You have to answer answers true or false. Please participate in this question. More 10 seconds. So most of the answers, 94%, go to the true. The mic with you, Dr. Jeff.
All right, thank you. So I may have misled you in that the answer is actually false, that in our healthcare system, we have introduced a risk stratification scoring system in order to perform our root cause analyses using HVACs, but it's not absolutely necessary. It's a really helpful adjunct in terms of the prioritization of your resources, but you can simply integrate your HVACs taxonomy into your existing root cause analysis models and prioritizations without having to actually add that layer of a scoring matrix. It would really depend, again, on how many events you're finding are being reported, as well as how you've resourced your investigative teams and the capacity they have to take on a specific volume of events. If you're spending a lot of time investigating very low-level events that are not yielding a lot of value in terms of system redesign, then that priority matrix may be helpful so that you can invest more time and energy in those higher consequence events. So at this point, I want to summarize this evening's presentation with these key takeaways about the human factors analysis and classification system and human factors in healthcare. First of all, integrating HVACs with root cause analysis methods yields higher fidelity learning. Think about all those different factors that we identified, all those contributors, the organizational, the supervisory, the preconditions that are maybe not typically thought of as we investigate events. The HVACs taxonomy becomes a bit of a checklist for the investigators to ensure that they've really looked at every opportunity, at every potential precondition before stating that they've concluded their investigation. HVACs deepens our understanding and increases the recognition of the interface between caregivers and the healthcare environment by giving us that structure and those different categorizations to think through it. It's more than just the ergonomics, as I mentioned at the top of the hour. It's not just about the physical interface, but it's also about the cognitive processes. It's about the mental and medical state of the individuals, their ability to operate within the environment that's been designed, and to highlight those opportunities for redesign, whether physical redesign or workflow redesign, maybe even redesigning the standards that we are hiring to, or for finding that the cognitive and the skill-based errors are overly frequent. And then lastly, driving improvements in the action planning process with the hierarchy of actions adds to the value of HVACs integration, because HVACs calls out more of those details that we can then apply that action hierarchy to, with a focus on those stronger or at least intermediate actions, and really try to avoid the use of those weaker actions, since they aren't going to bring about substantial system redesign functionality. So that concludes my presentation, and at this point, I will be happy to take questions.
Thank you very much, Dr. Jeff, for addressing this interesting topic. Dear participants, so we are now going to move on to the question and answer section. As a reminder, to submit questions, simply click on the question and answer icon at the bottom of your screen. Then type your question and select submit, so that Dr. Jeff can answer these questions as possible. We ask that you keep your comments brief and focused on today's topic, please. Go ahead. So it seems we don't have that much time, so we could pick one or two questions as quick. So I have a question for you, Dr. Jeff. When is the best time to start HVACs in my organization or in the healthcare organization?
So the beauty of introducing HVACs into your root cause analysis process is that you can do it at any time. Simply choosing when an appropriate time would be, maybe if you have some staff who are turning over and you'd like new staff to learn a new methodology, that could be a great opportunity. If there's if you look at your historic data and you see trending over time that there are periods where there are less events occurring, that would also be a good time to introduce HVAC, so that you can do the modifications to your process before volumes pick back up again, because it does require some training of your investigators to familiarize them with the taxonomy. And then, of course, you want to make sure that the resourcing is in place as well. If you have to create any new electronic tools that support it, or if you were going to acquire software that would support application of HVACs in your investigations, you'd want to time the training and the implementation after you've acquired that software and integrated it into your systems.
Thank you, Dr. Jeff, for this explanation. And I have just one more question. Yeah, this is one question from Riham. She said, what is the potentials of applying HVACs within EHR Advanced and the introduction of machine learning models and all within healthcare?
Well, that's a terrific question. You know, there's so much opportunity emerging with machine learning and augmented intelligence and natural language processing. The downside of relying solely on that is that many findings from investigations, from a conversation between the investigator and a healthcare worker involved in an event, will uncover perceptions that are not documented in the electronic health record. So creating that capability within the EHR would add to your HVACs process. It would identify things ahead of time that begin to frame the investigation more than necessarily a human review of the record would do. But you would still be reliant on that human-to-human interaction, because we tend to uncover so much in terms of behaviors and unspoken cultural elements that simply don't show up in the medical record. So a great way to augment the learning and to accelerate the investigation, but still not enough to completely replace the human investigation.
Thank you, Dr. Jeff. This is the end of our session. On behalf of the Saudi Patient Safety Center, we would like to thank Dr. Jeff Harman and the audience for their active participation. As a part of the Saudi Patient Safety Center efforts to provide you with timely topics and interesting speakers, we would appreciate it if you would fill out the evaluation survey provided at the end of the session. Thank you for joining us today, and we look forward to welcoming you back in the future webinar. Thank you, Dr. Jeff.
You are very welcome. Thank you for moderating, Dr. Asyabi.
Yeah, see you soon. Thank you very much. Have a good night, participants.